Fertility, 1 in 6 people. Same struggle, different story. Nobody talks about it honestly. Until now, 1 in 6 people worldwide will face a fertility challenge in their lifetime. That's not a rare problem. That's your colleague, your sibling, your best friend, maybe you. And yet most of them will spend months, sometimes years, confused, ashamed, and searching for answers that nobody gave them clearly. This video is that conversation. Honest, science-backed, judgment-free. Stay with me. Let's start with the reality, because the numbers are bigger than most people realize. Around 17.5% of the adult population, roughly 1 in 6 worldwide, experience infertility in their lifetime, according to the World Health Organization. That translates to approximately 48 million couples and 186 million individuals globally facing fertility challenges, and critically, the prevalence is comparable across high, middle, and low-income countries. Infertility does not discriminate by geography or wealth. As WHO Director General Dr. Tedros put it, the report reveals an important truth: infertility does not discriminate. Yet the silence around it persists. The shame continues, and millions of people navigate one of the most emotionally demanding experiences of their lives without accurate information or adequate support. Today we change that. Here is what we are covering: what fertility actually is and what affects it, the causes in both women and men, the myths doing real damage, the treatments with real evidence, the emotional truth nobody talks about, and what you can do, starting now. Section 1. What is fertility? And what does infertility actually mean? Let's build the foundation, because a lot of confusion starts here. Fertility is the natural capacity to conceive a child. It is not binary, it is not simply fertile or infertile. It exists on a spectrum, influenced by age, health, timing, biology, and dozens of other variables. Infertility is clinically defined as the inability to achieve a pregnancy after 12 months of regular, unprotected intercourse, or after 6 months if the woman is over 35, given that the timeline for intervention becomes more critical with age. Here is what most people do not know going in. About 85% of couples conceive within their first year of trying. Only 7% conceive in their second year. This means if you are in that first year, statistically, the majority of people in your situation will conceive. But if you are not among them, you are not alone, and you are not without options. Around 90% of infertility cases can be treated and managed thanks to medical advancements in the last 30 years. That number deserves to be said again. 90%, treatable or manageable. The problem is not the medicine. The problem is the delay, the silence and shame that keeps people from seeking help until years have passed. Does fertility feel like something that only happens to other people, until it doesn't? You are not alone in that. Let's keep going. Section 2. Causes of infertility. What's actually happening? Here is the breakdown that reframes almost every conversation about fertility. In heterosexual couples facing infertility, 1/3 of cases are due to male factors, 1/3 to female factors, and 1/3 to a combination of both or unknown causes. Male factors contribute to about 50% of all infertility cases when you account for combined cases. And yet the conversation, the testing, the blame, the Googling at midnight, falls disproportionately on women. This has to change. Fertility is a shared biology. Female causes. Ovulatory dysfunction, the most common female cause. Irregular or absent ovulation, often linked to PCOS, thyroid disorders, elevated prolactin, or hypothalamic disruption from extreme stress or low body weight. If ovulation is not happening consistently, fertilization cannot occur. Fallopian tube damage, blocked or scarred tubes, frequently caused by previous pelvic infections, STIs, or endometriosis. STIs are a leading cause of preventable infertility in both men and women. Endometriosis, tissue similar to the uterine lining growing outside the uterus, causing inflammation, adhesions, and structural damage to the reproductive organs. Affects approximately 1 in 10 reproductive age women and is frequently undiagnosed for years. Diminished ovarian reserve, fewer eggs than expected for a woman's age, diagnosed through AMH, anti-Müllerian hormone, testing and antral follicle count. Can occur earlier than expected in some women, which is why baseline fertility testing in your late 20s or early 30s provides valuable information. Uterine factors, fibroids, polyps, or structural abnormalities affecting implantation of a fertilized egg. Male causes. Male infertility is underdiagnosed and undertalked about, and that needs to change. Sperm parameters are assessed via semen analysis, looking at count, motility, ability to swim, and morphology, shape. Age affects all genders' fertility, and studies show that increased paternal age is associated with increased risk of miscarriage and genetic conditions. Varicocele, enlarged veins in the scrotum, is the most common correctable cause of male infertility, present in approximately 15% of all men and 35% of men with primary infertility. Hormonal imbalances, low testosterone, elevated FSH and LH, or elevated prolactin can suppress sperm production significantly. Lifestyle factors, heat exposure, saunas, laptops on the lap, smoking, excessive alcohol, obesity, and anabolic steroids all measurably impair sperm quality. Unexplained infertility. In some studies, up to 59.6% of infertility cases are classified as unexplained after standard investigation, meaning no clear cause is identified through routine testing. This is not a dead end. It often responds to treatment. But it is deeply frustrating to be told there is no answer when you are living the question. Section 3, Age and Fertility, the honest conversation. Let's talk about age, because the conversation around this is both too alarming and not clear enough simultaneously. A woman in her late 20s has roughly a 20 to 25% chance of conceiving per menstrual cycle. By age 35, this decreases to about 15%. By age 40, it may fall to 5%. These are averages, not individual sentences. Science confirms that age affects fertility, yet biology is not destiny. Many people conceive naturally after 35, some even without difficulty. What changes is probability, not possibility. At birth, the ovaries contain all the eggs they will ever have. The quality and quantity of these eggs decrease naturally over time, with the rate of decline accelerating meaningfully after 35. But here is what gets less attention. Male fertility declines too. Hormonal changes affect male fertility, impacting sperm production, mobility, and motility. There is increased risk of miscarriage, birth defects, and certain conditions with increased paternal age. Fertility is a two-person biology. The age conversation belongs to both partners. And for those wanting to extend their options, egg freezing before age 35 offers the strongest outcomes, as younger eggs have a higher chance of leading to a successful pregnancy in the future. Ovarian induction uses the same hormones as the natural cycle, and retrieving eggs during this process has no impact on future natural fertility. Section 4, Myths versus Facts. Now let's dismantle the myths, because they are delaying diagnoses, misplacing blame, and costing people years. Myth 1. Infertility is mainly a woman's problem. Fact. About 1/3 of infertility cases are attributed to male factors, 1/3 to female factors, and 1/3 to a combination of both or unknown causes. Male factors contribute to around 50% of all infertility cases when combined causes are included. Fertility testing should always begin with both partners simultaneously. A semen analysis is faster, less invasive, and less expensive than most female fertility investigations. Myth 2. If you just relax, you'll get pregnant. Fact. While chronic stress can influence hormonal balance and cycle regularity, infertility is a medical condition, not a state of mind. A healthy lifestyle can improve the odds, but cannot override age, genetics, or underlying health conditions. Telling someone to just relax minimizes a real clinical situation and delays appropriate care. Myth 3. You've had a baby before, so you can't be infertile. Fact. Infertility can impact you even if you have been pregnant before. Secondary infertility, difficulty conceiving again, becomes more prevalent as both partners age, especially after 35. A previous pregnancy does not guarantee future fertility. Myth 4. A healthy lifestyle will fix infertility. Fact. There is not much evidence that most lifestyle changes are silver bullets for infertility, and even less evidence that a healthy diet or supplement can fully counteract the fertility decline that happens with age. Lifestyle choices work alongside biology, not in replacement of it. The exception that matters most, smoking. Women who smoke reach menopause an average of 4 years earlier than non-smokers, making quitting one of the highest leverage actions available. Myth 5. IVF always works. Fact. IVF yields a clinical pregnancy rate of approximately 46% per cycle in studied populations, but this varies enormously with age, diagnosis, clinic, and embryo quality. IVF is the most effective assisted reproductive technology available. It is not a guarantee. Understanding the realistic numbers before starting treatment helps set expectations and supports better decision-making. Myth 6. Fertility is only relevant when you're trying to conceive. Fact. Fertility is a window into your broader hormonal and reproductive health, at every age. Irregular periods, painful cycles, and abnormal hormone levels are signals worth investigating now, regardless of family planning timeline. You always have the agency to take control of your reproductive health. Which myth have you heard most? Drop it in the comments. I want to know what needs the most debunking in your world. Section 5. A real story. Let me share a story, one that plays out in millions of homes around the world. Sarah and James had been trying for 18 months. Both assumed the problem was Sarah, because that is what every conversation, every magazine article, every well-meaning family member seemed to suggest. Sarah went through 6 months of tests, supplements, lifestyle changes. James came to one appointment. When a full semen analysis was eventually done, James had a severe motility issue. Treatable, fixable, but delayed by 18 months because no one suggested it sooner. They started treatment. 7 months later, Sarah was pregnant. What they lost was not a medical outcome. It was 18 months they will never get back, months spent in the wrong direction because the default assumption was that fertility is a woman's issue. About 1/3 of infertility cases are due to male factors. Both partners should be tested. From the first appointment. Always. Section 6. Treatments that actually work. Around 90% of infertility cases can be treated or managed with medical intervention. Let me walk you through the options, in order of invasiveness and cost, so you understand what the journey can look like. Level 1. Lifestyle optimization and timing. Before medical intervention, understanding the fertile window, the 5 to 6 days around ovulation, maximizes natural conception chances. Ovulation predictor kits, cycle tracking apps, and baseline temperature monitoring are accessible starting points. A diet rich in healthy fats, fish, poultry, whole grains, fruits, and vegetables is associated with improved male and female fertility. Avoiding smoking, limiting alcohol, maintaining a healthy weight, and moderating exercise intensity all support reproductive health. This is not the whole answer, but it is the foundation that everything else builds on. Level 2. Medications for ovulation induction. For women with ovulatory dysfunction, medications like letrozole or clomiphene citrate stimulate the ovaries to produce and release eggs. These are often the first clinical step, relatively low cost, non-invasive, and effective for a significant proportion of cases with ovulatory cause. For men with hormonal imbalances, targeted hormonal treatment can improve sperm production meaningfully. Level 3. IUI, intrauterine insemination. IUI is a relatively simple and affordable fertility treatment where a partner's or donor's sperm is washed and concentrated before being inserted directly into the uterus at the time of ovulation. IUI has an overall clinical pregnancy rate of approximately 3.3% per cycle in studied populations, better for mild male factor infertility, unexplained infertility, or cervical factor issues. Often recommended before IVF as a less invasive first step. Level 4. IVF, in vitro fertilization. IVF is the most recognized and most effective ART available. Eggs are retrieved from the ovaries, fertilized with sperm in a laboratory, and the resulting embryos are transferred to the uterus after 3 to 5 days of development. IVF yields a significantly higher pregnancy rate, approximately 46% per cycle, compared to IUI at 3.3% in direct comparative studies. In 2021, 2.3% of all infants born in the United States were conceived through ART, 99% of which was IVF. Fertility treatments like IVF can cost $15,000 to $20,000 or more per cycle, making financial accessibility one of the most significant barriers in fertility care globally. Level 5. ICSI, intracytoplasmic sperm injection. ICSI is an IVF procedure in which a single sperm is injected directly into an egg. It is the primary treatment for severe male infertility, including very low sperm count or motility, where standard IVF fertilization rates would be poor. Fertility preservation, egg and sperm freezing. For those not yet ready to conceive but wanting to protect future options, egg freezing before age 35 offers the strongest outcomes. Egg freezing does not impact natural fertility or reduce chances of conceiving independently in the future. It simply provides additional options if needed later. Sperm banking is simpler, less invasive, and highly accessible, relevant for men facing medical treatments that may affect fertility, or those wanting to preserve options for the future. Section 7. The emotional truth, mental health and fertility. This section exists because fertility is not only a physical journey, and nobody says that loudly enough. Depression rates among infertile women are higher than in the general population. Men with male factor infertility have more symptoms of depression and anxiety and lower self-esteem. In a survey, 51% of respondents reported depression as a result of infertility, and 46% reported anxiety. Stress can harm fertility by disrupting hormonal balances and reproductive health, creating a painful loop where the emotional weight of trying affects the biological systems involved in conceiving. The grief of infertility is real, and it is disenfranchised grief. Nobody sends cards. Nobody takes time off work. Nobody always knows what to say. And yet the loss of an expected timeline, of a pregnancy, of a version of the future you imagined, is profound. Here is what helps. Seek specialist psychological support. Fertility counseling is distinct from general therapy and addresses the specific emotional landscape of diagnosis, treatment, loss, and decision-making. Communicate with your partner. Fertility challenges change relationships. The same event lands differently on two people. Create space for both experiences without requiring them to be identical. Connect with community. Online and in-person fertility support groups reduce isolation measurably. The most powerful thing for someone navigating infertility is hearing from someone else who has been in the same waiting room. Know when to ask for help. If anxiety or depression is persistent, it deserves clinical attention alongside fertility treatment. Mental health is reproductive health. If you are watching this in the middle of a fertility journey, I want to say something directly to you. What you are feeling is valid. The frustration is valid. The grief is valid. The hope is valid. All of it, at the same time. And this is what the science says clearly. Around 90% of infertility cases can be treated or managed. That is not a platitude. That is a clinical reality, built on 30 years of reproductive medicine advancing faster than at any point in human history. The path forward may not look like you imagined. It may involve testing you didn't expect, treatments you didn't plan for, timelines you didn't choose. But there is almost always a path. The first step is the most important one. Get accurate information, get both partners tested, and find a clinician who takes your history seriously. You are not alone in this. And you do not have to navigate it in the dark. If this video gave you something, clarity, validation, one myth you can stop believing, one question you now know to ask. Like this video. It takes 1 second and it helps YouTube show this to more people who are searching for honest information right now. Subscribe. We cover reproductive health, fertility science, and evidence-based wellness every week in exactly this format. Human, clear, shame-free. Comment below. Tell me, what is the one thing you wish someone had told you earlier about fertility? Or what question do you still have? I read every single comment. Share this with the couple trying to figure out where to start. With the woman who has been carrying this alone. With the man who has never been told this affects him too. With anyone who deserves better information than they've been given.